Thank you for this opportunity to present at this research forum, and I'd love to interact with anyone with any questions. I'm sure. Here's the outline of the study of the talk. I'm going to be just introducing radiopharmaceutical therapies, as the title suggests, just what it is, and go through a review of some recently FDA-approved clinically used theranostic agents, some research agents that are upcoming, and then the role of dosimetry, and then go through some of the infrastructure that we're building at UW to take on these new agents. So what is theranostics? So many of you probably have heard this term. It's a term it's an area that's really rapidly growing and becoming, pretty important, a growth area, an area of opportunity. So theranostics is actually a made-up term. It's a combination of the words therapeutics and diagnostic. So it's known by multiple other names, which you can be familiar with, and it really talks about the same process. So it can also be known as radiotheranostics, talking specifically about radiopharmaceutical or radioactivity with theranostics. There are an area of theranostics that does not involve radioactivity. That's a different area. But for most terms for now, theranostics really implies radiotheranostics. Some people spell it with the G, with the theranostics. Other people spell it without the G. And radiopharmaceutical therapy, radioligand therapy, other people call it peptide receptor radionuclide therapy, or PRRT, but they're really referring to the same thing. So theranostics really is the term to describe the combination of one radioactive label on a drug to identify a target, and a second radioactive label, a different one that's on the same drug, to deliver a radiotherapy or targeted radiotherapy to that tumor or metastatic disease. So for instance, in here, as you can see, you have a tumor that has a specific target, a specific antigen receptor or transporter, and then you have a molecule that targets that. So this is a schema and a concept that I'm sure you're all aware of and probably actively involved in investigations. However, what we have is a radioisotope that's labeled to this targeting molecule that allows for both imaging and therapy. So that's typified, illustrated here. So in this particular agent, which is, and we'll talk more about this and you'll become familiar with this agent, PSMA for prostate cancer. So this agent itself has an imaging diagnostic agent, or fluorine-18 or gallium-68. They're two different agents that does the same thing. For PET imaging, which can diagnose the tumor and show where the tumor is, the extent of the tumor, and how viable it is. But we can then have the same molecule that targets the same target, that the ligand that targets the same molecule on the tumor cell, but then switch the radioactivity to, in this case, lutetium-177, or a radiotheranostics agent or label for therapeutic purposes. So the same target, but different radioactivity for different purposes. And some of the imaging that we do here is called PET imaging. There are PETs that get imaged here at the UW campus, but on the veterinary hospital just down the road from the medical campus. But this PET really refers to positron emission tomography. So it's kind of a fancy name and a fancy concept, which actually is a really cool way of imaging tumor that's been around for the last 20 years and is really gaining a lot of momentum. So as you can see on the screen left, basically a positron is a radionuclide radioactivity that once there's a decay of radioactivity, the positron interacts with an electron and emits two gamma rays that are 180 degrees apart. And so that detection is made once that event happens. And then you have basically thousands of these events happening, millions of these events happening that can then detect the radioactivity. And then here on the screen right is an example of what a PET image looks like. And so the areas that are dark, and this is fluorodeoxyglucose, this is the workhorse of oncologic PET imaging right now clinically. And so this, you can see the brain activity, some tonsillar activity, some urine activity here through the kidneys and the bladder. And so this is a patient who has a normal FDG PET scan. This is a patient who has widely metastatic disease. So all of these dark black spots here are sites of metastatic disease. And this patient, unfortunately, had a very large pelvic bone metastatic site here. So this is using FDG, or fluorodeoxyglucose, or a glucose analog, exploiting the glucose metabolism of tumor cells. And this is an agent, this is one of our new PSMA agents, or prostate-specific membrane antigen agents for prostate cancer, just showing normal distribution. These are lacrimal glands, these are salivary glands here, and the normal expected uptake and excretion in the kidneys. And there's actually some uptake in the proximal tubules of the kidneys, liver, spleen, and some bowel activity. But all of these spots here, so this is actually the tract of urine, but all of these spots are sites of metastatic disease probably in the retroperitoneal and pelvic lymph nodes, and probably a bone metastasis here for this patient. So I'm just a little bit of fun here. So, when we do these PET imaging, we usually do this as a PET CT or PET MRI. So what are we doing? So similar to the task of a radiologist who has to find the tumor site with hundreds of sections on a CT scan of a patient. So this is an example from a textbook by Dr. von Schaltis from Switzerland. So this is a CT scan, grayscale imaging. And in this image, you're supposed to find this previous lowly worm. And so can you find this lowly worm? And I have to admit that the resolution of the image is not great. So I'm kind of setting you up to kind of fail here. But when you take a look, you really have to look at a lot of normal structures, and you have to look for abnormal structures within here. So PET imaging, however, and actually he's supposedly down here inside this little Apple car. So PET imaging here is functional imaging or molecular imaging, where you're targeting and having accumulation of the radioactivity in a specific area that's metabolically active or has target that you're looking for. In this PET imaging, you don't see a lot of anatomic structure necessarily, but you can really highlight and target and really light up the area that you're worried about. In this particular case, a lot of times for oncologic imaging, although we do cardiac and neurologic imaging as well. So how do you combine both of these? So you can then combine both modalities. You can have the molecular or functional imaging combined with the anatomic imaging and have the benefit of both. So you can actually highlight the lowly worm that we want to see, but in the context of all the other stuff that's going on in this patient. And so that's what we do when we do PET CT imaging with fusion imaging, multimodality imaging. We actually can see the activity, and then we can actually see this activity represented anatomically here in this fused PET CT image. We also have other modalities, a PET MRI scanner as well in the basement of Wimmer, where we can do both functional PET and MRI imaging. So this is what we do for diagnostics. That's the diagnostic component of theranostics. But where does the theranostics come from the radiation targeting? So, when we do external beam radiation therapy, it delivers the same absorbed radiation dose per cell. So basically you have radiation that's sent from outside of the patient and goes through the cells, and regardless of the number of cells. And actually there's a lot of pioneering and expert work done here at UW in the radiation oncology department and medical physics department, trying to kind of shape these radiation beams to basically maximize the activity and focus the activity to the tumor and minimize the activity to the surrounding normal tissue. So there's much fancier ways to do this than just straight activity like this. However, if you have a patient like this on screen right corner, this is a patient with widely metastatic disease seen on our prostate cancer imaging with PSMA PET imaging. This patient really is not amenable to focal treatment or surgical resection. However, we really require systemic therapy, and we have immunotherapy and chemotherapy. However, to deliver radiation therapy to these cells really requires a systematic approach. So that's where theranostic comes in. So with these theranostic agents, when you actually inject the radioactivity into the patient, it distributes throughout the patient and then targets these areas. So the areas that you're able to see light up on PET imaging are areas that are getting the radioactivity to the patient. And as really well delineated here by Dr. Segouras in this really nice review article here on emerging theranostics, the absorbed dose per cell is influenced by a number of factors, by the range of the radioactive emission, the number of tumor cells that are clustered together, number of cells that have been targeted, and the density of the radioactivity that's targeting the tumor cells. And however, a single cell is very difficult. Oftentimes you're sort of cross-firing and missing the activity, but a cluster of cells you can hit. So basically a way to systematically or systemically distribute the radioactivity and then treat the tumor cells, especially in multifocal metastatic disease. So the type of radioactive activity that we use for therapy, and there are a number of them. There are Auger electron emission, which we are in development, but really not clinically applicable currently, except in some clinical trials. However, the workhorse right now is some of the agents that I'll talk about is lutetium-177, which has a half-life of 6.7 days, or really about, so basically half of that activity, if you just leave it alone, will decay in 6.7 days. And this lutetium and 177 will actually cause beta, or beta activity will actually cause single-strand DNA breaks and cause cell death. But we have these alpha therapies, which are very much more radio-dense therapy, which actually causes double-strand DNA break. Now, the radiation types here are illustrated here. The alpha therapy, which is essentially a helium atom, is very energetic, so very has dense ionizing radiation. However, is not able to travel very far, and usually a piece of paper will block that radioactivity, whereas the beta activity will be able to get through paper but not get through plastic. So if you've done some radioactivity in the lab with like P32, sometimes just the plastic shielding will be sufficient, as well as just clean handling with gloves and just safe hand washing to prevent radiation exposure. And then higher energy gamma rays will require concrete, steel, or lead to really block that emission. So there's a number of different therapies that use these radionuclides. So the workhorse, the one that's been around probably historically the longest, is iodine-131 for papillary thyroid cancer, and that has a half-life of 8 days. It's a beta emitter. Radium-223 is an alpha emitter that was recently approved. That has a half-life of 11.4 days. And radium-223, for historic purposes, was what Marie Curie discovered and saw glowing in her laboratory, and actually had ultimately died from exposure to radium-223. And lutetium-177 that I talked about, which we use, it's a beta emitter and has a half-life of 6.7 to 6.6 days. So the number of publications by tumor type in theranostics has really grown exponentially over the last 20 years or so. So in a variety of different tumor types, as you've seen here. So there's been a great number of interest and progress in this area. In terms of also expected revenue, so a lot of these agents are going to a clinic, and the pharmaceutical industry is really interested in developing these agents, as you can see here. And this is an older slide, but really shows potential expected agents coming online in the market. And then in purple here is the radiotheranostics market here in terms of revenue growth. So currently approved FDA agents that are used includes, and just to give you a bit of a historic purpose, iodine-131 used for thyroid cancer was developed during the war, and the first patient it was administered to was in, I think, 1939, and a lot of that development, I think, was hampered by the war, and then really accelerated after the end of World War II. Yttrium-90, so we've been using that iodine-131 for a number of years. So if you talk to some older nuclear medicine physicians, they'll tell you Theranostics was around for decades, and that is true. However, there's been a lot of recent developments and acceleration in this field beyond I-131. So yttrium-90 is another radioactivity that people have been using on microspheres for treatment of liver metastatic disease or primary liver cancer, and basically are directly injected into the liver through the hepatic artery, and then goes to that specific distribution. And that's been around since the early 1990s. And very recently, radium-223 or what Marie Curie was using was actually used to treat bone metastatic disease, and that was approved in May 2013. And then over the last few years, these two agents, lutetium-177 dotatate or NetSpot for neuroendocrine tumor, was approved in January 2018. And then most recently this year, the spring of this year, lutetium-177 PSMA 617 or Pluvicto was approved in March 2022. So really acceleration in the field, and there's a lot of research being done, and hopefully there'll be more agents approved shortly for clinical use. So the number of clinical available agents are listed here. I updated this slide to add our Pluvicto or a PSMA agent, and then another agent that we use here, especially at UW. There's a big program here led by the Pediatric Oncology Group and Ken DeSantis and his Pediatric Oncology Group using I-131 MIBG for neuroendocrine, for neuroblastoma. So a number of these agents that are used clinically and actively used here. When you take a look at the types of clinical trials that are being done in the United States, and this was just a survey of the clinicaltrials.gov website in September, basically there are 20 listed just for PSMA therapeutic agents worldwide, and 13 were recruiting, 4 not recruiting, and 3 were terminated using a variety of different PSMA agents. Some are elaborations of the current approved agents, and then other agents that are in development. So a lot of activity being done. And beyond PSMA, there's a lot of theranostic applications being done for different targets. So this is an older slide, but really typifies really the excitement in the field, because I think it really limits you. I think the only limit is really based on just rational design and just the type of viable targets that you can find. So one area is somatostatin or bombesin or gastro-releasing peptide receptors, an area for active investigation. Another area could be CXCR4, or other areas where it can really be used to target not just prostate cancer or neuroendocrine tumor, but a variety of different tumor types affecting different organs and different systems. And when you take a look in terms of the agents that are in development, this slide is just meant to show just a number and variety of agents in different phases of clinical development, and just to highlight CLR-131, which is an agent developed here at UW-Madison by Jamie Weichert and his group here that has been used in a variety of solid tumors and multiple myeloma that are in clinical trials currently. And he has a newer, second generation agent, which is very exciting and in clinical translation right now. So after all this, so if you're not excited about this already, I guess the question is, why all the excitement? Why all of the investment in this? And I just want to tell you the reason for that is really that these agents are very effective. So this is a Kaplan-Meier curve, or a patient progression-free survival and overall survival curve for the NETTER-1 trial. So this was the pivotal, the landmark trial that led to the approval of lutetium-177 dotatate, or Lutathera, for neuroendocrine tumor. And in this New England Journal article that published their results, the progression-free survival in green for lutetium dotatate compared to the control, which is just standard of care octreotide treatment, really showed at the time of the analysis here really didn't even meet 50% of the progression-free survival, and there was a statistically significant increase in overall survival. And so when you take a look in a little more detail, so the median progression-free survival was not reached at the time of the statistical analysis, and octreotide alone, which is the standard of care, had a median progression-free survival of 8.4 months. 19%, or 201 patients, had evaluable data, experienced complete or partial response, whereas with the lutetium dotatate, with the radiotherapeutic agent, versus just 3% of the patients assigned the standard of care agent, which was statistically significant. And then the overall survival data at the time of this publication in 2017 had not yet matured. However, 13 patients in the treatment arm group with dotatate had died, whereas 22 died in the octreotide arm, which was also significant. And then 23 patients assigned to the dotatate arm died during the course of the study or experienced disease progression, compared to 67 in the octreotide group. So this led to these robust clinical trial data led to the approval of this agent. And then transitioning to the most recently approved agent is prostate-specific membrane antigen. So PSMA is a type 2 membrane-bound protein. It's really highly expressed in prostate cancer. And for that reason, it's been developed, and we currently are using it, and was FDA approved for PET imaging for prostate cancer, which was really an area that was in need of development, as there's not really much, previously there was no real good agent for prostate cancer detection. So because of this, as a good target, there's been theranostic agents that have been developed for this. And this image here, which is a dramatic image, really illustrates how effective these therapies are and the promise of these agents. So if you take a look, this was the Society of Nuclear Medicine and Molecular Imaging 2018 Image of the Year. So every year at this meeting, at the annual meeting in June, they select an image that is really highlights big advances in the field. And this was the advance in 2018. This was by the Peter MacCallum Cancer Center in Australia. And their group really did amazing work, very detailed, systematic, prospective studies looking at the efficacy of lutetium PSMA 617 in these patients with advanced castration-resistant prostate cancer. So if you take a look in all of these little boxes on screen left, in red are sites of metastatic disease. So these patients had pretty extensive metastatic disease, and the number on the bottom is the PSA level. And then after these patients were treated with lutetium PSMA and followed up, the screen right in these little boxes are basically the image showing you many of these patients have imaging negative, undetectable disease. Some have a little residual by PSA, but are image negative. And so really showing you the dramatic effects of this lutetium PSMA agent, a theranostic agent, in treating patients with advanced metastatic prostate cancer. So really advanced in their disease. Many of these patients had reached the end of the road in terms of viable treatment options. Here's some other images just to show you what these are just anecdotal images, just showing you what the patient, the extent of disease. These dark spots here are sites of metastatic disease here. And then during treatment, we can actually image some of the radioactivity from the lutetium PSMA, and then how these patients do afterwards. Some of the other real excitement in the field is that some of these patients treated with lutetium PSMA do progress, as you see here from A to B, this patient showing worsening disease. The PSA is increasing from 294 to 419, but then the patient gets treated with an alpha agent. So if you remember, these are kind of like the energetic helium atoms that really are radiodense and cause double-strand DNA break. So the cells don't have time to necessarily recover with the DNA strand break. So these patients actually then respond very, very well when they were otherwise resistant to the beta radioactivity, to the alpha radioactivity. And then these patients, the PSA, otherwise the white cell counts and everything else look relatively stable, whereas there was a dramatic response in PSA. So there have been some systematic trials that have been done, and this is the pivotal landmark trial that was done for lutetium PSMA for prostate cancer that was published in 2021. This was an international open label phase 3 trial, and out of a total of 831 patients enrolled in this trial after screening, and they treated patients with really at the very kind of late stage disease. So patients with metastatic castration-resistant prostate cancer who were previously treated with at least one androgen deprivation therapy so these are targeting the hormone receptor for these tumor cells, and treated with 1 or 2 taxane-based chemotherapy regimen, so targeting the tubules in the patient. So the patients also had PSMA positivity for gallium PSMA PET-CT. So they were imaged with the PET-CT scans showing that they actually did have target and took up this radio ligand. And then the patients were randomly assigned in a 2-to-1 ratio to receive either lutetium 617 with protocol permitted standard of care therapy to continue that therapy, or just the standard of care therapy alone. And these are really, these are the Kaplan-Meier curves showing the percent of patients with disease progression. So in blue, you can see over time since the treatment and randomization, the patients with lutetium-617 did better than patients with standard of care alone. And this is based on image-based progression-free survival, so based on imaging findings. And then when you take a look at overall survival, you can also see that the 617 plus standard of care therapy had statistically significant improved overall survival compared to standard of care alone. And so the standard of care therapy, lutetium PSMA plus standard of care therapy, it significantly prolonged of the following as compared to just standard of care alone. Image-based progression-free survival, 8.7 versus 3.4 months. And then overall survival, 15.3 versus 11.3 months. And then the incidence of adverse events was a little bit higher with lutetium-617, 52% versus those on standard of care therapy, which is 38%. However, it was considered that the quality of life was not adversely affected with this treatment. And then the most adverse events that was seen in these patients receiving this therapy was fatigue and dry mouth. And as I had shown earlier, the activity goes to salivary glands, and so dry mouth is one potential side effect for these patients, but nausea, anemia, decreased appetite, and constipation. And then the most common abnormality that worsened from baseline were blood counts and some calcium and sodium, which we follow carefully in these patients on treatment. So what are new other emerging theranostic agents? And so, you know, the potency of these agents really in delaying progression or showing improving overall survival really is the reason for the excitement in the field for these agents. And so many new radiopharmaceutical agents are in development, targeting different things, targeting different tumor types. However, the other area that's really an exciting area is that combination therapy. So the combination of radiopharmaceutical therapies with immune therapy really potentiates the immune activity in these cells, in these patients, combination with DNA damage, sensitizing agents to potentiate the radiation damage to the tumor cells, external combination with external beam radiation therapy, different combinations of radionuclide. So a lot of emerging theranostics. And I just want to highlight at UW, this really a great study that was done. And just to highlight, this work was done with by Jamie Whitekurt and Zach Morris and Rainier Hernandez, which are all faculty members within radiology, med physics, and radiation oncology. And so really just as you see down here highlighted, so the combination of TRT or targeted radionuclide therapy with immune checkpoint inhibitor therapy or immunotherapy activated the production of these inflammatory cytokines in the tumor microenvironment and promoted tumor infiltration by these T cells and reduced metastases. And in mice bearing these tumors, combination of this targeted radionuclide therapy with external beam therapy, targeting a single tumor augmented response to immune response to compared to combination of these alone. So basically what they're saying is that really low dose targeted radionuclide therapy can really promote the response of the immune system or the immune therapies to many tumor types, regardless of the location. So this is great work done here at UW and really showing how combination and these combination therapies really show a lot of promise for treating patients with metastatic disease. So, you know, I think for this specific talk, I think many of you can may be asking, so how is this done? This does involve radioactivity. And so it's, you know, I think there are new issues that might arise for this. So, so how this is done, and just to give you a sense of how these rooms are set up. So this is an image and picture of one of the rooms in the AFCH that's a special lead-lined room to treat pediatric patients with neuroblastoma with I-131 MIBG. And so you can see what these are provided to me by John Haas from Radiation Safety, and really shows how the room is basically covered so that you don't have any radiation contamination, because the half-life is such, then you'd have to wait a long time and the room would be out of commission for a long time before you can use it again. And then you have a radiation detector that's over the patient, so they're constantly monitoring these patients and give a readout for these patients who are sometimes hospitalized for about 3 or 4 days before they can meet release criteria to be discharged. and be safe to leave the hospital. And then the bathroom itself is very well covered here as well. So this is what radiation safety does a great job here at UW providing support for these patients. Here's an outpatient treatment. So, however, a lot of the patients that we're doing are really outpatient. So lutetium, PSMA, or Pluvicto, and Lutathera are done outpatient. And this is a room that we've just sort of kind of put together in the nuclear medicine area, the radiation or dosing room, and the chair here is covered, and I think we're getting a nicer, bigger chair soon. And then there's a less extensive, but still covering on the floor here to catch any radiation contamination. This is a lead lined infusion pump that we have with some of these patients. So the Lutathera gets a 30-minute infusion, and then the Pluvicto gets a 1 to 10-minute infusion. And then this is a handheld radiation survey detector that we could have available just to look for any radiation leaks or detection in these patients, just to give you a little bit of sense of how these rooms are set up. And for many of the research studies, they may be set up in the CRU. However, in preparation, because of all the excitement and the growth of this area, our center here at UW, as well as many centers, academic centers across the country, are really setting up these theranostic centers. And so the East Park Medical Center, as you all know, construction is expected to be completed the second half of 2024, has built in 5 treatment rooms with 1 dedicated large room and dedicated PET-CT, SPECT-CT for the imaging needs and dosimetry needs for these patients, as well as radiopharmacy and other areas that are nearby, as well as an interventional radiology procedure room for these yttrium microspheres. So it's going to be located next to the current American Center or East Madison Hospital. This is a schema just showing how the room is set up. And so these are theranostic suites that have been designed kind of with the team and with radiation safety kind of concerns, where there's an ante room and a patient toilet room and a multi-purpose room here for research studies. The SPECT scanner and PET scanner will go here. So how are these treatments given? And so these treatment regimens for many of these patients require a specific dose. This is the schema here for lutetium PSMA, where we give a typical dose would be a 200 millicurie dose separated every 6 weeks. And then if a patient is otherwise not having adverse events, then we'll get 200 millicuries up to 6 doses for the patient. So up to 6. The Lutathera has 200 millicuries every 8 weeks for 4 doses. And then we follow these patients with FDA approval has included dose adjustments. So we look for hematologic or other renal or liver toxicity for these patients. And depending on if they have toxicity within the treatment follow-up period after the treatment, then we could either hold a dose or give a modified dose, which are kind of predefined, either 20% for Pluvicto or 50% for Lutathera. And then if the patient recovers, then we can give that half dose and then continue the treatment in that way. So there is a schema for these and oftentimes predefined dose adjustments. We do go through radiation safety, which I know is a concern for those who are not familiar with these agents. And so this is a patient kind of education kind of handout that we have for the Pluvicto patients. And so for Pluvicto patient, we advise basically to temporarily abstain from any reproductive kind of sexual activity. And then the number of close contact, I think this on the chart here is where we spend a lot of our time to really limit the contact and prevent any unnecessary prolonged precaution for about 2 days, staying more than 3 feet away from each other. Usually they sleep in a separate bed, and up to 7 days for pregnant women or children, and to really kind of self-isolate themselves for a number of days so that the radiation effects are minimized to those around them. Many of these patients, actually all of these patients and all of the research patients have close involvement of a radiation safety officers and authorized users, who can be the nuclear medicine physician typically, but also radiation oncologists as well. And for radiation safety information and address any radiation safety issues. And then we go through guidances, and depending on the patient situation, there are different radiation safety issues that arise. So, as you've seen here, the current treatment regimens are currently, there are some dose adjustments, but they're typically one size fits all, a single 200 millicurie dose for every patient, and 4 to 6 cycles, depending on the treatment. So the question is, are we undertreating these patients and depriving them of the maximal benefit of the targeted radionuclide therapy or theranostic agents? Or are we maximizing the therapeutic benefit while minimizing toxicity? Those are the two goals that we want to have and the questions that we have. So, the current one-size-fits-all theranostics that we have here, this is for Pluvicto, which is 6 cycles, basically image the patient, show the tumor has uptake, and then we give the standard doses, is currently a one-size-fits-all paradigm. However, the whole field, and we really want to move this field along to more personalized treatment with involvement of dosimetry. So what we do is, after the initial treatment, the patient undergoes the imaging from the radioactivity in the treatment to get serial SPECT CT imaging. And then based on that, we can actually, based on the distribution and clearance of the radioactivity and how long it stays in the tumor and the activity that's present in the tumor, can determine the radiation effects to the organs as well as the tumor, and deliver personalized doses to decide potentially the dose that the patient can get, but also how many cycles they can get for optimized treatment response. And how this is done, and this slide is courtesy of Brian Bednar, who heads our dosimetry program here at UW from the Met Physics department, is really measure the activity, and then we do that by different imaging modalities, either by specs, usually by SPECT CT, but or we can potentially do it with PET CT, and then really we delineate all the organs, basically draw a region of interest around the specific organs or tumors, and then calculate the dose that's deposited in those areas over a period of time. And this curve here really typifies, that the activity is clearing from the organ. So it's really the amount of activity over time, and then the radiation effects of that organ in terms of the radioactivity deposited within that organ, and then organs nearby with radiation effects there, and trying to determine how much radiation activity that specific organ or tumor is getting. So a very complicated process, but an area that the Med Physics department here and our program at UW is really well situated to handle. And a couple of just, publications which highlight this. So in 2013, and Europe, because of the regulatory setup there, have had a lot of experience with these agents, with Lutathera. And so in these patients, what they found is they took a look and did dosimetry and looked at the dosimetry, and based on current absorbed dose limits, based on external beam radiation, 23 grade to the kidneys and 2 grade to the bone marrow, try to see, based on the dose limiting organ to kidneys and bone marrow, how can we adjust these treatments to these patients, and found that 50% of the patients could have theoretically tolerated more than 4 or up to 10 cycles of treatment. So current cycle is 4 for dotatate, and 20% of patients could not tolerate the standard 4 cycles. So the authors noted half of the patients treated with the fixed 4-cycle regimen were being undertreated with respect to possibility given the dosimetry allowances. And then for PSMA, what they found is over multiple cycles of treatment, the cumulative dose delivered from lutetium PSMA may approach or exceed the activity that you would have treat with these tumors based on external beam treatment. So the tumor dosimetry really shows that we're delivering a high dose to these tumors and potentially can deliver more. And so because of that, I think one of the proposed dosimetry methods is to really do intensive dosimetry and try to do more imaging to personalize the treatment for these patients. And to that effect, at UW, just to highlight just the team and our multidisciplinary team that's at work here, we've set up and we've been working as a UW dosimetry working group for a number of years with medical physics, radiation oncology, and ourselves in nuclear medicine, in conjunction with some students from Brian Bednar's group, and in collaboration with our radiation safety officers, our PET technologists, and our nuclear medicine technologist manager, Derek, and our 2 leads, Christine and Kelly. to really get this dosimetry working group together to do apply advanced dosimetry in the tumor patients. And also to handle the growing number of clinical studies, we've set up a Theranostic DOT, or a theranostic group, a multidisciplinary group by all three departments, radiology, med physics, and human oncology or radiation oncology, with myself, John Floberg from human oncology, and Brian Bednar from med physics. And we've just recently hired a new theranostic program manager, Megan Donner, who's our nuclear medicine technologist, who has experience and was our therapy lead before. And the picture here, and she's helping to manage our program here, and with her and help from Sarah Stewart from the Cancer Center Clinical Research Office, we're trying to set up good processes and workflows to handle a lot of these emerging agents. So currently, a lot of these trials, as you know, there are a lot of specialized functions that these trials require, which is the therapy dosing, so to dose the radioactivity, the imaging and dosimetry, a lot of the radiation safety. So this is kind of a schema that we're seeing that, for these trials, if they're multi-tumor phase 1, phase 2 trials, that the Theranostic DOT will really be able to interface closely with these dots and handle a lot of the theranostic functions. In a phase 3 trial that are maybe more theranostic agent is a little bit more familiar and used, there's more experience with this, then we can interact a little bit more with this DOT just to provide these service needs for the DOT for these studies. The dosimetry infrastructure can be pretty complex, and in this schema here provided by Brian Bednar really shows the number of things that need to be done. And just to really highlight the role of the radiation oncologist, nuc med physician, medical physicist, manager, and their nuc med manager and technologist to be able to do the imaging, make sure the scanners are well calibrated. Some dosimetry requires some blood draws, a lot of the image processing and calculations that are going to be done. And then if this is part of standard of care, billing or incorporation into the research study. So pretty complex infrastructure, again, needing a multidisciplinary team. And then for our multidisciplinary clinic or for our clinical research studies, there's clinical management for these patients, but once there's DOT enrollment for these studies, there's all of the role of a multidisciplinary team looking for the radiopharmaceutical administration, pre-therapy, the treatment and subsequent treatment adjustments, and then any dosimetry that's going to be done in these trials. And more of these trials require dosimetry estimates and imaging involved. But again, involving a multidisciplinary team, involving nursing, medical physics, again, as well as our dosimetrist and our nuc med technologist for the infusion, as well as our nuclear pharmacist to receive and to distribute these therapeutic agents. So I think, one thing to just highlight the program is because of the kind of the depth of our program, we've recently had a Society of Nuclear Medicine Comprehensive Center of Excellence designation, just to show the depth of research as well as clinical work that's being done. And so currently, I think there at this time was about 18 sites that have been designated for renewal every 2 years, but really just showing that the depth and breadth of things that are doing here. And again, just how well situated we are at UW-Madison to really leverage all of the imaging, medical physics, and radiation oncology expertise, as well as integrate with all of the growing oncology infrastructure here and studies to really take theranostics to the next level. So what are the theranostic opportunities at UW? So I think this has been a prioritization and a growth area that's really been a key area for UW School of Medicine, UW Health, and the Cancer Center, and I think also for AFCH for prioritizing clinical and clinical translational theranostic research programs in our center here. There's been development of the infrastructure, many of that you've seen that are currently ongoing and in development to really handle these complex clinical and translational research study needs. I think many other peer academic sites across the country are struggling with these because these are very complex multidisciplinary studies to allow for effective clinical and translational integration into these studies and to be able to work cross-disciplinary wise. And then growing the imaging and dosimetry expertise in these teams for development of advanced diagnostic applications at UW. So a little bit of a introduction to all of the theranostics and some of the terms here. I couldn't get into a little more of the detail in terms of how specific studies, but just want to end with this. So Yogi Berraism. So he said it's tough to make predictions, especially about the future. And I think this is particularly true for these diagnostics. He says, no matter what comes, I think one thing we're sure of is that the future is not what it used to be. So thank you for your attention. And this image here is a stained glass window from the National Cathedral in Washington, D.C., just showing, I think this one is highlighting Atoms for Peace, that I think which we're trying to do here in the Theranostics program. So thank you, and I'll take any questions.
If anyone, thank you, Dr. Cho. If anyone has any questions, feel free to drop them into the chat, or you can unmute. We'll just give it a few seconds here.
Dr. Cho, this is Tamara on the clinical research unit. So thank you again for this presentation, because it is very complicated, and trying to operationalize some of this in the clinical setting. You've just been extremely helpful with putting it in terms that is understandable to those of us at the bedside. So I just wanted to say thank you to that. And then just the future, like this is going nowhere but forward, is what I'm gleaning from this presentation and from the clinical trials that have been coming in. Will all of the theranostics in the future be carried out at East Campus? Will anything happen at University Hospital?
First, I want to thank Tamara for all your help in the CRU. I think you've been have been playing and will play a pivotal role in this. So I just want to thank you and just to acknowledge you and your help with all this, especially, dating back to the pre-pandemic. So thank you. But I think that's a question that we have on everyone's mind. I think it hasn't quite been decided yet. I think one thing is definitely for sure. I think they're definitely for clinical trials that can be done in an outpatient setting, and depending on how intensive maybe some of the trial needs are, can potentially be done in the East Park Medical Center. However, maybe some more intensive phase 1-2 studies, I think, may need to be done on the university campus here. And also depending on some radiation needs, or if there needs to be some, especially inpatient overnight stays.
Thank you.
Any other questions? I just had a quick question, Dr. Cho. You mentioned in one of your slides, first of all, I love the Yogi Berra quote at the end. That was really, really great. And just, this seems like a rapidly changing field. And you mentioned a lot of, that there are a lot of emerging theranostics happening. There are a lot of radiopharmaceutical agents in development. I'm just wondering what as you look toward the future, what you're most excited about. What you think holds the most promise with theranostics as we move forward?
Yeah, I think probably the two areas that are probably the most, I think exciting are probably dosimetry. That if we can, currently it is kind of cumbersome. So these patients have to get treated and they get the therapeutic dose, and then they have to come back for 3 scans, usually to get 3 time points and to develop the clearance curves for these patients. It is a lot of visits for these patients, although it's probably comparable to the imaging visits patients would need to come for external beam therapy or for some other chemotherapy. However, I think to make things easier for these patients, I think there's a lot of efforts to try to simplify the imaging. So maybe you could generalize the clearance from maybe one imaging time point. And I think there are efforts to try to do that. I think that's one area. Or instead of giving a therapeutic treatment dose and then getting the information, to basically have some other PET agent that can maybe, as a surrogate, tell you sort of what to expect when you give a therapeutic activity. And so there's, studies kind of being currently done to try to, to simplify and to predict some of the treatments in kind of the most convenient kind of, way that we can, so that the patients, don't have to come for multiple visits, which is not an insignificant issue at UW in Wisconsin. I think the other area I think is the paper that I showed, which from UW, just showing the potentiation. So I think one area that was kind of a breakthrough discovery in oncology is the immune therapy, so immunotherapy. So many tumors that otherwise, these patients could not really were at the end of the road in terms of any treatment, are now getting immune checkpoint inhibitor therapy or CAR T therapy and showing dramatic results. And so not all patients, but approximately 30% of patients show really prolonged stable disease or partial response, or sometimes even complete response. And so it's been really kind of an amazing development. However, I think the combination of this treatment with immune therapy really, in the work that's been done by Jamie Weichert and Zach Morris and Rainier Hernandez, I think really show you how the combination of these two new fields can really potentiate, activity from from either alone. And I think that's an area that's really, the combination therapies are the areas that are really exciting.